This is really an honor and privilege to participate in this prestigious meeting. I thank the organizers and Dr. Anna specifically. I was charged with giving an overview of the pathology of myositis. So this is a pathologist's perspective. Now, there's a bit of a introduction. A heterogeneous group of disorders in which the common feature is chronic inflammation of skeletal muscle leading to muscle weakness. Other organs are frequently affected, such as the skin, joints, lungs, and GIT, and this contributes to morbidity and mortality. Now, the classification, Dr. Iman has discussed it extensively and more than enough. Earlier on, it was divided into polymyositis, dermatomyositis, and inclusion body myositis, and this had its own limitations because subgroups often have overlapping clinical and histopathologic features. Outcomes vary within the subgroups, and subgroups without considerable myopathy are not included. The new classification is based on the presence of myositis-specific autoantibodies, and these are associated with distinct clinical features. And they can help in identifying subsets of idiopathic inflammatory myositis in which extramuscular involvement might be the presenting or the predominant feature when muscle symptoms are mild or absent. Now, the recognition of these subphenotypes with single organ involvement other than the muscles is important for identifying patients with early disease, for clinical care demanding team management, and in designing clinical studies to improve our understanding of this heterogeneous disease to develop new therapies. So the new classification includes dermatomyositis, inclusion body myositis, immune-mediated necrotizing myositis, and anti-synthetase syndrome. Now let's start with polymyositis. Now, polymyositis, the hallmark of polymyositis is the presence of mononuclear inflammatory cells surrounding, invading, and destroying apparently healthy muscle fibers. So you can see here, this is a muscle biopsy, and you can see that this muscle fiber is totally healthy and it is surrounded by this mononuclear inflammatory cellular infiltrate. And you can see that secondary changes can happen in the form of scattered necrotic and regenerating muscle fibers, but this is a non-specific feature, and actually it may confound the diagnosis. One of the very distinctive characters of this disease is that MHC class 1 antigens are strongly expressed on the sarcolemmal membrane of almost all muscle fibers. This is very distinctive. If you do, this is a confocal microscopy image to show you the types of inflammatory cells that are actually infiltrating and invading these normal muscle fibers. And as you can see, we're staining with two types of antibodies. CD3 is T cell specific, CD8 is suppressor T cell specific. And if you merge both stains, there's a perfect overlap, which means that the main cell type, indeed the sole cell type of inflammation involved in cases of polymyositis is the suppressor T cell. And this can actually aid in the diagnosis of this condition. So this is a resume of what we've just said. So it's a mononuclear cell infiltrate. It may occur in the perimycelium and rarely at perivascular sites because the site here is specific to contrast with other types of myositis. And we have to bear in mind that there are non-specific histologic abnormalities as increased variation in fiber diameter, scattered necrotic and regenerating muscle fibers, and increased perimyceal and endomyceal connective tissue. These are actually perplexing features that I shouldn't take into consideration when I'm diagnosing polymyositis. So just to show you a better picture, this is MHC class 1 expression in cases of polymyositis, and you can see here very strong expression which delineates the sarcolemma of each and every muscle fibers. In contrast, necrotizing autoimmune myopathy may have some weak, scattered, incomplete expression of MHC class 1. So this is a way that we can use immunohistochemical staining in the form of confocal microscopy to aid us in the diagnosis of the exact subtype. So we have diffuse MHC class 1 sarcolemmal immunoreactivity in a muscle biopsy. And in necrotizing autoimmune myopathy, we have scattered incomplete staining of the sarcolemma of necrotic fibers. So from the morphology, we can actually deduce the pathogenesis. So it is a cell-mediated cytotoxic reaction in which CD8 cells are the main infiltrating cells, and they attack the muscle fibers which overexpress MHC class 1 molecule. And these T cells, the suppressor T cells, have cytotoxic granules which induce the fibrosis of these infiltrating muscle fibers. Let's contrast these findings with dermatomyositis. So in dermatomyositis, you have that inflammatory infiltrates, as you can see here. They are in perivascular sites in the muscle biopsy or within the interfascicular septa. So these are the main types of inflammation. It's actually a sort of vasculitis. MHC class 1 antigen is usually not expressed on the sarcolemma in cases of dermatomyositis, and if it is present, it's weak and focal. So this is another aspect where we can use immunohistochemistry to differentiate between these two cell types, in addition to morphology. Rarely do we see inflammation in the endomycelium, and the infiltrating cells, the ones we saw around the blood vessels and in the interfascicular septa, are mainly CD4 helper cells. You may find some plasmacytoid dendritic cells, these are macrophages, and CD8 T cells and NK cells are rare or absent. So this is a very important, so we have two differentiating points as regards immunohistochemistry to differentiate between polymyositis and dermatomyositis, the morphology and phenotype of inflammatory cellular infiltrate, and the extent of expression of MHC class 1 on the sarcolemma. What other findings do we find? So these are single or clusters of muscle fibers in various stages of necrosis and regeneration. So this is a common feature which we can see between both polymyositis and dermatomyositis. And the main histologic hallmark is the distribution of the atrophic, regenerating, and degenerating muscle fibers at the periphery of the fascicle. Perifascicular atrophy involves both types 1 and 2 muscle fibers, and it may affect, if you go down from perifascicular collagen and we count up to 10 layers, it may involve all these layers. And even in the absence of inflammation, active inflammation, vasculitis, and the interfascicular inflammation we've just seen in the first picture, this is strongly supports the diagnosis of dermatomyositis. So the distribution of the affected fibers, in addition to the immunohistochemical phenotype of the infiltrating inflammatory cells and the MHC expression can aid in the differentiation between both diseases. This is an angiopathy. It's mainly an angiopathy, as we've seen in the perivascular infiltrates. You have immunoglobulins and complement, and specifically the membrane attack complex C5-9. And we have reduction in the number of capillaries with endothelial hyperplasia, with enlargement of the lumen of the remaining capillaries. So the vascular changes are very important, and they are very prominent in the diagnosis of dermatomyositis. On electron microscopy, if we're lucky to have this tool, we can see tubular reticular lesions in the endothelial cytoplasm of the arterioles and capillaries. So the muscle affection is actually a secondary form of affection, secondary to the vasculitis, which is present. It's a complement-mediated microangiopathy, and we've just discussed the vascular changes which we see in this disease. The third type of myopathy is immune-mediated necrotizing myopathy. In this case, we see randomly distributed necrotic muscle fibers with various stages of regeneration and degeneration, and importantly, there is a very sparse mononuclear inflammatory cellular infiltrate, which is a very distinctive feature of this disease. MHC class 1 expression is not present. If it is present, it's weak and focal, and the membrane attack complex can be seen in a few cases. And the infiltrating cells, if any, are actually macrophages. You do not have T or B cells in this type of myopathy. So immune-mediated myositis is found in viral infections, connective tissue diseases, malignancy, and in cases of statin therapy. And its pathogenesis is still elusive. We don't actually understand the exact mechanism. Sporadic inclusion body myositis. In this disease, distribution and the immunophenotypic profile of the inflammatory cells are similar to those we see in polymyositis. And again, what do we see in polymyositis? We see CD8 positive T cells infiltrating and surrounding apparently healthy, normal, non-necrotic muscle fibers. And there is strong expression of MHC class 1 on the sarcolemma of the affected muscle. So histologically, we actually cannot differentiate between this entity and polymyositis. Sometimes we see amyloid fibers, which fluoresces when stained with Congo red and viewed under polarized light. And by EM, we can see these tubulofilamentous inclusions inside the cytoplasm. And sometimes by histology, we can see these rimmed vacuoles in the affected muscle fibers. And here you can see CD8 positive cells and strong MHC class 1 expressions, exactly similar to what we saw in cases of polymyositis. It's still enigmatic as regards its pathogenesis. So we have endomycelial inflammation and muscle fiber degeneration, and the extent of contribution of each of these processes to the pathogenesis is not fully understood. So in cases of the differential diagnosis of myositis, we aim to accurately specify the type and to rule out the mimics, which are associated with secondary inflammation of the muscle. This is a very disappointingly long list of other diseases which may mimic idiopathic myositis. So we have muscular dystrophies and metabolic myopathies, and it's a very long list. Okay. So I actually was going to go into the detail of the mimics of myositis, but I think the time will not permit detailed description. This is just a go-through list of the important entities. So we have brachiocervical inflammatory myopathy, severe sporadic late onset nemaline bodies myopathy, and drugs. Many of the drugs that are used may induce a myopathy. Zidovudine induced mitochondrial myopathy may coexist with HIV-induced T-cell mediated myositis. Inflammatory changes can be found in cases of treatment with procainamide, depenicillamine, which are dermatomyositis-like and
أول واحد
polymyositis-like, chloroquine and amiodarone affecting microtubules, especially colchicine and vincristine, can induce a myopathy. Steroid myopathy presents with subacute proximal muscle weakness and type 2 fiber atrophy. And of course, if it occurs in the course of treatment of idiopathic myositis, may be mistaken for an exacerbation, leading to more aggressive steroid treatment rather than its withdrawal. Thyroid evaluation is important because both hypo and hyperthyroidism can cause myopathies. Evaluation of adrenal function, because both hyper and hypo adrenal function can cause lesions, and hypo and hyper parathyroidism can cause myopathies as well. Diabetes, of course, can cause a certain type of myopathy and muscle weakness. The list of genetic diseases which causes myopathy is very long. Actually, I have never seen one of these. So it's a list taken from the literature. So genetic defects in the spheruline gene causes muscular dystrophy, female carrier of dystrophinopathies, adult onset acid maltase deficiency, and mitochondrial myopathies. Thank you.